Good afternoon. Welcome to Grand Rounds today. Please remember to fill out the attendance records at the back of the auditorium, and also please remember to fill out the program evaluations, and especially the last question that asks if there are any future topics or speakers that you'd be interested in seeing or hearing. Today I have the pleasure of introducing Dr. Linda Lehman. Dr. Lehman is an ophthalmologist in the Department of Ophthalmology at the McFarland Clinic and here at Mary Greeley Medical Center. She did her training in ophthalmology at the Gunderson Clinic and then moved on to the Mayo Clinic in Rochester. She has kindly accepted the CME Committee's invitation to provide us with some clinical pearls in ophthalmology today, so please join me in welcoming Dr. Lehman.
Thank you. Can you hear me? This is on okay? Okay, great. So I want to thank the CME Committee for this series on clinical pearls. I've really enjoyed some of the presentations, for example, Jamie's, and I look forward to endocrinology next week. The CME Committee, in addition to saying clinical pearls in ophthalmology, did task me with 4 different areas that people have been interested in. One is brain tumors, one is visual field defects, another is uveitis or inflammation in the eye, and the last is how the eye and systemic disease may be related. So since each one of these topics could be a grand rounds by itself, by necessity this will be fairly basic. This is to get your attention. 4 people in the room have a brain tumor. How do I know this? We didn't scan you as you walked in. This is just statistics, okay? So there's a fairly well quoted study in cancer, and this was an autopsy study and an imaging study, and they combined. It was a meta-analysis. And it's believed to be pretty good science that about 16.7% of us may have a pituitary, might be a microadenoma. So it may be as small as 0.4 millimeters or up to 5 millimeters. Now these would be asymptomatic. I'll look forward to Dr. Al-Makaid telling us next week about the symptomatic ones. But unfortunately, that's not why the CME Committee asked me to speak today. They asked me to speak today because unfortunately, there can be some brain tumors that cause a lot of morbidity and mortality. And 14,000 adults probably died in 2012 from a brain tumor. Brain tumors also occur in children. Fortunately, that is at a smaller incident rate. Unfortunately, they tend to be a little more malignant in that age group. So we want to know who gets brain tumors. Mostly because of the incidence of meningioma being higher in women. Women are 56% of the population with brain tumors and men 44%. But men aren't so out of the woods because unfortunately, men tend to get the more malignant brain tumors. There is a race predilection as well. If you're white, you have the highest incidence, with the exception of blacks have a higher incidence for meningiomas, pituitary neoplasms, and craniopharyngiomas. The least amount of brain tumors occurs in people of Asian Americans and Native Americans, and Hispanics are intermediate. The most common symptoms, or the most common symptomatic brain tumors would be gliomas and meningiomas by far. So gliomas, astrocytomas are about 50% of symptomatic brain tumors. Meningiomas, if you include those that are found on just imaging studies alone, that may be up to 40% of brain tumors. And rounding out the top 5, pituitary neoplasms, lymphoma, and craniopharyngiomas. In children, it's somewhat similar, but it tends to be more broad across the map. So again, astrocytomas and gliomas. Unfortunately, this is still a significant issue because the 5-year survival for malignant brain tumors is only about 1/3. So we want to know who has a brain tumor. When they walk into the office, they don't come labeled, so we're trying to figure this out. These are the common symptoms of brain tumors: headache, new seizures, new double vision, difficulty walking or talking, changes in mental status, and persistent vomiting. So when this patient walks into your office, you want to know, okay, am I going to follow this patient? Am I going to image this patient? Or am I going to refer this patient? Headache, according to the WHO, in the last year, 47% of us have had a headache. I don't think 47% of us need an MRI, So we're going to try to figure out, if a patient walks in with a headache alone, when do we need to be concerned? This is a little bit different from how I learned it. I learned it was one side and it was very severe, and those are the people you need to worry about. But recently, we've discovered that it's more the constant, dull headache, and it can be localizing. It tends to be bifrontal, but it tends to be the side of the tumor that's worse. These headaches tend to be worse at night, may or may not resolve with medication, and in older patients. So the incidence of headaches is different depending on your age and sex. The highest incidence of headaches is women 18 to 44. The lowest incidence is men over 75. So if a 70-year-old male patient walks into the office, has never had headaches, and has a new headache, that's somebody you want to image. I went backwards. Sorry about that. So what we're looking for with headache is an increased intracranial pressure headache, and the classic triad is headache, nausea, and papilledema. It can make it worse with body position. If papilledema is severe, it's very easy to see. But if it's subtle, it's a little more difficult. And we do have, in addition to our clinical opinion, which I think hasn't been replaced, we do have a tool called an OCT, and I can show you some of those if we have time at the end of the talk. So this is a patient with severe papilledema. Pretty much everybody can see that there's blurring of the disc margins here. There's also tortuosity of the blood vessels. This is another slide. This patient also has significant papilledema, but if you look at the blood vessels, even this tiny one really isn't blurred. So this area, there is not a lot of disc margin blurring that can occur elsewhere. So it's not as easy as it always seems. And again, if you're not sure, send them on over. So in addition to headache, then a symptom of brain tumor might be new seizures. A seizure can be a symptom of a glioma or a metastasis. Now, one of the papers that I looked at in preparation for this talk said that 10% of us will have a seizure in our lifetime. So the question is, do you have a reason to have a seizure? Are you hypoglycemic? Are you inebriated? Is there something going on? If you have a reason, then you probably don't need a study. But if it's your first seizure and it's unprovoked, an MRI is a good plan. I think one of the reasons that I was asked to talk today about brain tumors is because of diplopia. Double vision is something that can be very confusing for people. So we're going to try to make it very simple. It's amazing to me that we don't all have double vision more. I mean, for us to have binocular vision in all these positions, it requires 3 cranial nerves to each eye and our 6 eye muscles all working together in every position. What I'm going to present here is my experience with double vision. Most commonly, I see a 6th nerve palsy. So the 6th nerve innervates the lateral rectus muscle. So here's my eyeballs. The lateral rectus is moving the eye out. So if you have a 6th nerve palsy, you're going to end up with horizontal diplopia. The images are going to be side by side. Since the lateral rectus is pulling the eye out, if that's not working, the eye will be in. And the double vision will resolve when you cover one eye or the other. In general, this is the one that I tend to be the least worried about if they are over 45 and they have a history of diabetes or hypertension. I generally don't image these because the vast majority of them will resolve. And what we do is we say, come back in a month, we measure the double vision again, and if they still have double vision at that time, they are going to be imaged. So I image right away if they're a young person, under 40 to 45, if they're not diabetic and not hypertensive. Otherwise, we talk about dealing with diplopia, covering one eye, or perhaps there is a option of putting on what's called a Fresnel prism on a lens. And that is a little $40 piece of plastic, and I've had a patient tell me, this $40 piece of plastic makes me functional when I was non-functional with the double vision. So you can cover one eye, and in fact, in the hospital, I've sometimes taken a Kleenex box and just put a Kleenex over the patient's glasses. But I don't encourage them to occlude the eye all the time because we want some impetus for them to return to binocular vision. This is our patient with a 6th nerve palsy. So this person walks into the office, but this person is actually 20 years old, so he gets scanned right away. And unfortunately, you can see the pretty gross abnormality there. So from the 6, the next most common that I've seen in my practice here is a fourth nerve. The fourth nerve innervates the superior oblique muscle, which depresses and intorts the eye. So trying to make it simple, if it's right, I think right, left, right. So a right fourth is going to be a right hyper. It's going to be worse in left gaze, and it's going to be better with right head tilt, and you can flip them around for left. So the cranial nerve 4 exits from the brainstem. It has a long course to the superior oblique muscle, so it can be damaged in addition to ischemia from trauma. You also can be born with a fourth nerve, and you tend to find the spot where you don't have double vision. So this particular patient had a head tilt even as a child, and then as an adult. This is after strabismus surgery. Cranial nerve 3 is a little tiny bit more complicated because you can have, as with any of these, a partial or a full. So the superior division of cranial 3 does the things that are up, lifting the eye up in the superior rectus. The inferior division does the other recti muscles that we haven't talked about in the inferior oblique, and the take-home point, the pupillary sphincter, okay? So that's an important thing for your third nerve. This is our patient with the third nerve palsy. The patient walks in, and they have this eye completely closed. If you lift up this eyelid, and this eye is down and out, the next thing I do is I pick up the phone and I call my friendly radiologist because I want an MRA or a CTA. But to go through this, the patient looking in this direction we're doing okay. But you look in this direction and you've got very substantial double vision. The patient is unable to look up. Here's the normal eye that can look up, this eye cannot. So take-home point again, a pupil-involved third nerve palsy is an aneurysm until proven otherwise. The most common would be posterior communicating artery, but it can be the internal carotid or the basilar. So who gets an image with the third nerve? Pupil involved, and that is a MRA or a CTA. Otherwise, an MRI, children, patients under 50, unless you're completely comfortable and confident that they have long-standing diabetes, maybe they have other ischemic areas of their body. If there are other cranial nerves involved, then they also need an image. I'm going to talk about giant cell arteritis when we get to the systemic portion of the talk, but I'm just going to throw it in here because think when you have an isolated cranial nerve palsy, could it possibly be giant cell arteritis? So the patient who has pain with chewing, scalp tenderness, and generally doesn't feel well, the tests you want for that are a C-reactive protein and a SED-rate. So back to brain tumors, the meningioma, these are the benign brain tumors. And of the schwannomas, the most common is going to be an acoustic neuroma. Generally, the pituitary adenomas would be the one I would choose, benign and slowly growing. The bad cell types listed here. Back to the glioma. So it's a spectrum of tumors. If they don't have anaplastic change, that's how come they're called benign. But when the life expectancy of a diffuse astrocytoma is 7 years, it's not particularly benign. Meningiomas, these are fairly common again. So there was an aging study done where 2,000 people were imaged. Of those 2,000 people, they found 18 meningiomas that had no symptoms. Meningiomas tend to occur in women. They tend to be older. And in addition, they are associated with neurofibromatosis too. So symptoms again, so I can drill this into your head. Headaches, new seizures, double vision, which you're now all an expert on, difficulty walking or talking, changes in mental status, and persistent vomiting. There are risk factors for developing a brain tumor. We all know, unfortunately, from the atomic bomb that radiation is a risk factor. A child may receive radiation and then force something, and then as an adult, they're going to be more likely to develop a brain tumor if they've had radiation, particularly to the head as a child. If you live in a developed country, they did try to correct for our neuroimaging dramatically more, and it's still presumably a risk factor. White, there are occupational risk factors electrical, oil refinery, agriculture. In addition to those environmental risk factors, there are genetic risk factors: neurofibromatosis 1, neurofibromatosis 2, von Hippel-Lindau, and basal cell nevus. How many of you have your cell phones with you? That has been reported as a risk factor. But the radiation, the radio frequency actually has not been proven. So I'm still using my cell phone. And obviously you can, depending on what type of tumor and where the location, depends on how you treat it. This is my segue now from our brain tumors to our visual field. So one option that I sometimes consider as an inexpensive imaging option is doing a visual field. The eyes receive the image, it goes through the optic nerve, it crosses at the chiasm, the optic tract, you've got the optic radiations, and they go back to the occipital lobe. So all of that has to be pretty normal to have a normal visual field. So that's something to consider as well. So I think it's very important to know how to test a visual field. So I have a very friendly volunteer. This is my nurse, Polly, who volunteered to do this. A lot of times a patient will come into your office and they'll say, I can't see out of my left eye. Well, maybe they can't see out of their left eye. You know, maybe their vision is 2400. Check their vision. It's a vital sign for us. If they're 2400 and 20/20, maybe it is the left eye. But at least half the time, when they say they can't see out of their left eye, they mean they can't see their visual field to the left. So you want to test this, and this is the way I think is best to test. So I'm going to be eye level with my patient, and I'm going to say, Polly, would you please cover this eye? Okay, so I have my eye where hers is, and then if I hold my fingers about halfway, I'm going to be able to see what she says. So I say, with your eye on my eye, can you see my eye? That tests for a central scotoma. With your eye on my eye, can you see my whole face? Paracentral scotoma. Okay, and then partially functioning as well. Okay, with your eye on my eye, how many fingers do you see?
3.
And how many here?
4.
Okay.
3.
Okay, so I generally will do 1, 2, or 5 fingers because it's hard to tell 3 and 4. Now, cover your other eye. Say she can't see part of it, well then I'm going to do the same thing. Start with the eye, the whole face, and then I'm going to do the fingers individually.
1,
So,
5.
and test the whole areas. Okay, thank you, Polly.
You're
Appreciate that. So she does lots of things for me, and I appreciate it. And appreciate the support of my whole department. So this is visual field defects. You can read that in your handout. Here's the picture of the pathway that I went through with you. So things off to the left, things off to the right. The only time it's going to be the left eye or the right eye is if it's the eyeball itself or the optic nerve. Once we get to the chiasm, the visual information will, some of it will cross and into the tract radiations and back to the occipital lobe. You can see how the visual fields might look, but we're going to simplify it. We're keeping things simple today. In addition to that pathway, I wanted to talk briefly about transient visual field loss. So migraine is very common. We talked about those women 18 to 44. Some of them have migraine, some of them have visual phenomena. So if the patient comes in and they are telling you that they're seeing a kaleidoscope or some geographic things, it may be colors, it may be clear, it may be a circle, it may expand, it may move through the visual field. If a patient has a known migraine, I don't think you need to do much. If the patient does not have a known migraine, then you might want to send them for an eye exam. In addition, emboli is something that we want to not miss. So what we're worried about is amaurosis, which would be a hemifield loss of vision. It's temporary, superior, or inferior. We're concerned about this being embolic, and the most common in my experience is a carotid embolus. It can also be from the heart. So when I have a patient that I feel has amaurosis, the test I'm getting is a carotid ultrasound. Now, if they're in my office, I'm going to take a picture if I see a reason and get a visual field. So this is a printout of a visual field where they have a midline defect. And this happens to be the little culprit. So this is a cholesterol embolus that has most likely come from the neck and past here. Sometimes when you look at the eye, you have that normal red reflex and you can see a white reflex. This may be from a number of reasons, but ischemic retina is a possibility, and there's the culprit here. And the reason it's horizontal is because of the way the nerve fibers are arranged in the eyeball. So this would be where the optic nerve exits the eye and then It's a horizontal midline defect because of the nerve fiber arrangement, the anatomy. So we're talking about visual field defects front to back. If it's one eye, we're going to say it's either the eye or the optic nerve. So a couple of examples, the eye would be something like macular degeneration, or the optic nerve, maybe an optic neuropathy. Here's a few other examples that are listed. Remember, if it's one eye only and you're worried about a tumor, it's going to be an orbital tumor, not a brain tumor. Now we're back to the chiasm. So this is a classic chiasmal visual field defect, bitemporal. They don't have to be the same. So a compression, a pituitary neoplasm. You can have other visual field defects that can be similar or not similar, and the rule to think about for these is after you get past the chiasm, the more anterior they are, the more asymmetric they are. The closer you get to the back of the visual pathway into the occipital lobe, the more symmetric the defect. So this is a printout of a visual field that you might get. This is a normal visual field right here, this part. This is where the optic nerve exits. This is the left eye, this is the right eye. Here's the abnormality. That's a very congruous abnormality. So we would expect that perhaps to be more posterior. This is a complete homonymous hemianopsia, and unfortunately this is the only visual defect that is not truly localizing. When you get to the back of the eye, the occipital lobe, a lot of times you'll have that homonymous hemianopsia with the central part spared, macular sparing. So you've made it through half of the topics, but we're going to breeze through the rest here. Uveitis, this is the inflammation in the eye, and most commonly probably is idiopathic, but it also can be HLA-B27 positive, and we'll talk about some of that. Don't forget post-operative. So if a patient comes in with a red eye and they've had a surgery within the last month, they probably need to see their surgeon, particularly their eye surgeon. If the patient had something taken out of their eye last week and they come in with their conjunctivitis, don't give them an antibiotic drop. They may have a post-traumatic iritis. You can have lens-induced, and we're going to talk about a number of other things with uveitis. So anterior uveitis and iritis are terms that tend to be used interchangeably. So it's inflammation of the uveal tract. These can be of various severity. So in the anterior chamber, if it's fairly not very severe, a lot of times we'll just see some circulating cells. More moderate would be some cells and some flare, so it looks a little hazy. And I think some of the severe ones then tend to have fibrin in the anterior chamber. So pain, redness, and photophobia. One little symptom you might look at in your office if you're wondering if this might be uveitis would be they're sensitive to light not only in the eye that's red and sore, but if you shine the light in the other eye, they may be equally sensitive. That can be a sign of uveitis. So again, a little eye anatomy, and I'd be happy to review that with anybody who wants to go over it more, because of course I love the eye. So here's the iris, ciliary body, and choroid. Inflammation of these is a uveitis. The choroid is this black tissue. Sometimes you can see that if the sclera is a little bit thin. And the Greek anatomists thought it kind of looked like a grape. So a grape is uvea, and that's how we get the uveitis. So again, the patient walks into your office, they have a red eye. You want to know, is this uveitis or is this conjunctivitis? Uveitis is generally more painful, more light sensitive. Conjunctivitis, it can be viral, it can be bacterial. It tends to be more discharged, maybe sticky. Often there's a family member or a coworker who has a red eye, and they may be ill as well. So if it's viral, then just cool compresses. And this is a wonderful thing you should know about. These are preservative-free artificial tears, and they can make the patient feel better, make them feel like they're doing something. So you can just knock the top off, drop them in. You can use them very frequently. I have had patients use them even every hour while they're awake. If there's time at the end or you're interested, I'll give you my bacteria antibiotic of choice. When to refer is if they're not improving in 3 to 5 days or back to normal in 5 to 7. In addition, if they have a history of herpetic disease, they should be referred right away. Herpetic disease can cause scarring to the eye. If they have a higher potential that this is a uveitis, like they have a known HLA-B27 positivity, ankylosing spondylitis, inflammatory bowel disease, what we learned as writers, but is now reactive arthritis or psoriatic arthritis. They have a higher likelihood, not that they can't get a conjunctivitis, but they have a higher likelihood of having a uveitis. So you might want to consider referring them, particularly if they don't have the pattern of some coworker with a red eye. I think about the most common disease that I see with the HLA-B27 positivity that has iritis is ankylosing spondylitis. So the classic for this would be a young male back pain, stiffness, SI joint space narrowing is one of the ways that you can tell this. Tends to be more common in men. They may have an elevated SED rate. Other HLA-B27 uveitis, Crohn's disease, ulcerative colitis, the writers, and the psoriasis. So how do we treat these people? Well, one way may be a red top, and I thought it might be interesting for you to see that drop colors, eye drop colors can vary. So it used to be in the old days when everybody was on either pilocarpine, which is a green top drop, or timolol, which we didn't have a sample of, is a yellow top drop. The patients didn't know their names, so you could say, well, what color eye drop are you on? By the way, the new prostaglandin that most people are on, they got to choose the color, so they chose teal. And again, we can go over some of these. This happens to be the other drop that we're going to be using. This is prednisolone acetate, so you want to shake this up well, and this will treat the majority of your patients with anterior uveitis. Probably just need those two, the cycloplegic, the topical steroid. Sometimes I will give them a nighttime steroid ointment such as FML. This is your warning, those of you who are queasy and don't want to see a needle and an eyeball in the same slide. The next slide you're going to want to cover your eyes because we're showing you periocular steroids. As far as systemic steroids, they tend not to be particularly effective in the eye, but I have had some good luck with pregnant women. And immune suppression, hopefully we don't get to that level, but unfortunately with some people we do. And then I generally ask my friendly rheumatologist to help me with some of those medications. So the promised slide. So a lot of times you can use a speculum. This is betadine to make sure everything is clean, and you can put the medication this, or we'll also be talking about some of the medications for diabetes can be injected that way. One of the most common, probably the most common posterior uveitis would be toxoplasmosis. Again, this can be associated with cats, tends to be unilateral. The patient may present with blurred vision, floaters, and light sensitivity. There is a classic appearance. This, first of all, is called the headlight in the fog. So sometimes if you're looking in the eye and you're having difficulty focusing, it may be because there's inflammation there. So optic nerve, veins, arteries. This is an old lesion. Here is a toxoplasmosis old lesion next to an active lesion, and this is a classic picture of the retina for toxoplasmosis. Herpes simplex I see relatively commonly, as I'm sure you do. The initial presentation is a systemic disease. They tend to be febrile, sick. So you should refer anybody if they have lesions around the eye or concerning their eye is red. This is herpes simplex. Unfortunately, this is an eye that had herpes simplex and has rather significant sequela. We'd like to see it a lot sooner than that. As far as herpes zoster, I gave grand rounds a few years ago, and I was really impressed because we did you answered the questions that time, and 80 or more % of you knew Hutchinson sign. So the V1 distribution, the nasociliary branch, that innervates the eye, and the tip of the nose. So if you have a patient with herpes zoster that has lesions below the eyebrow, on the tip of the nose, or any eye involvement, those are the people that you need to refer. Before you send them out the door, you probably want to go ahead and give them their script for your favorite antiviral, acyclovir, Valtrex, Famvir, whatever you like. So here is the V1 distribution. This patient needs a referral. They've got the vesicles, they've got this eyelid, and they do have some staining on the cornea. While we're talking about herpes viruses, acute retinal necrosis can affect the back of the eye. CMV I used to see a lot more of. Now that we're treating HIV much better, I haven't seen very much of this at all. So it generally is not very active unless your CD4 count is less than 50. I learned VKH as affecting Japanese people, and I wondered, why would I ever need to know this? And then a patient walked in with VKH. So headache, stiff neck, nausea, vomiting, tends to be women, tends to be younger, 20 to 50, and it's considered a disease of pigmented skin. So not necessarily just Japanese, but more common in Hispanic and Native Americans as well. I'm sure a lot of us have patients with sarcoid, and I find this an interesting bimodal race distribution as well, but sarcoid causes a granulomatous uveitis, and it can affect the eye from front to back. In general, I think a chest x-ray may be the most effective way of most information for the buck. If that's normal, then CT chest. We learned in medical school, you know, it's ACE, but that's only elevated in 60 to 90% of people who have active sarcoid. So sarcoid can be a bad actor in the eye. Posterior uveitis CME is cystoid macular edema or swelling at the center of vision and glaucoma. Behçet's, again, learned as, you know, the triad of oral ulcers, genital ulcers, and conjunctivitis. The current definition is just slightly different. Tends to be 20 to 40-year-olds. There's the HLA associations if you're interested, and remember the fibrin tends to be more involved, so they can have a significant uveitis. Wegener's, the couple of patients that I have tend to have more the sinus and orbital inflammation, but as you know, it's a systemic disease. I think C-ANCA is still fairly effective in diagnosing that. I did want to spend some time on juvenile idiopathic arthritis. There is a subgroup of patients that have these, and they tend to be 5 years old or less at diagnosis. Very commonly, they'll be 2 or 3. They have 4 or fewer joints, and the joints are going to be the wrist, the elbow, the knee, or the ankle. And it could just be one. They tend to be ANA positive, RH negative. So if you have a patient that is in that subcategory, they have a high risk for uveitis. The scary thing about these patients is they can look absolutely, totally, perfectly normal. And that is why we need to see them for an eye exam. And when they're first diagnosed, the current recommendation is seeing them every 3 to 4 months for the first 4 years. And then if they're not having active disease and they don't have eye disease, maybe every 6 months for the first 7 years, and then once a year if they have no sequela after that. And if you want to know, I can tell you about the patient that I had at Mayo Clinic who was undergoing her 30th surgery for this. She'd already lost vision in one eye. So here's some pictures that I think are rather informative. So here's the iris, and this is now focused in front of the eye. So this is the corneal endothelium, and this is inflammation that can be seen there. If you look at this one, here's the iris, and this is now defocused back. So this is a posterior subcapsular cataract, and those are consequences of juvenile idiopathic arthritis. Lyme disease, we're sort of in a Lyme disease area, so should be aware of this. And what causes it are tick, the Borrelia burgdorfia. So here's the classic skin lesion and the causative tick. We're on to the last section, so you guys have hung with me well. This is the eye and systemic disease. By far, the most common thing I see patients for is the systemic disease of diabetes. And diabetes does have very significant sequela, and early intervention can save vision. One of the most common things is swelling at the center of vision, diabetic macular edema. When a patient has microaneurysms, often that doesn't affect their vision substantially, but it does tell us that they are at risk of developing some of the larger or more significant consequences of diabetes. Neovascularization, retinal changes of the vessels. And in the old days, people used to go blind from retinal detachment. Unfortunately, I have actually seen a few of those people. So just an example of what you might see. Optic nerve, here's the macula or center of vision. These are hard exudates, and they do tend to be associated with some swelling. We have our new kid on the block, which is our OCT, and this has really helped us to follow these patients. So this is a normal retina, all the layers of the retina here. This is the center of vision, and it has this nice depression. This is a patient with some with the opposite appearance, so some cystic changes. So you can follow and measure, and we can get quantitative numbers for the macular edema as well. Just a cartoon about vitreous hemorrhage. The changes can be in the retina and, of course, in the vitreous as well. So here's a very bad example, in my opinion, of neovascularization. And these blood vessels tend to be leaky, so you can have blood in the retina and in the vitreous. This is a pretty old slide. I mean, it looks pretty dated, but I decided to use it anyway because this is sort of our classic way of treating diabetic retinopathy, laser. So that's a patient at getting their laser. These are the new kids on the block. Vascular endothelial growth factor causes or influences those abnormal blood vessels to grow. This, I think, is pretty amazing that somebody was brave enough to take Avastin, a colon cancer drug, and inject it in the eye. But they did that for macular degeneration and found some pretty amazing results. So now, in addition to laser, or maybe instead of laser, a lot of time anti-VEGF medications, these are the 4 currently on the market, can be injected into the eye, and you can have a very good result. So remember to send your diabetics. Type 2, it's every year. Type 1, often there is a sort of a honeymoon. You've got 5 years or so before you're likely to develop any retinopathy. Next issue in the eye and systemic disease is hypertensive retinopathy. These are some of the changes that you can see. So I like this because it shows the AV nicking. So generally the veins and the arteries are going to be about 2/3 the size of the vein. If the artery perhaps is a little stiff, it may push on the vein and you get this classic appearance of AV nicking. So hypertensive retinopathy, these are pretty extreme examples, but you can see the changes that can occur at the macula in the retina. I promised you I'd talk to you about giant cell arteritis because I don't want you to miss it. Take home point. They have a headache. Maybe you palpate over their temporal arteries and it's a little sore, particularly if they have pain with chewing, pain with combing their hair. Very rare under 55, but unfortunately there have been a few reports. So if the patient is over 50, you might want to consider a SED rate. Remember, the lab normal is a little higher than what we consider our panic mode. So SED rates, they're half of the age for male, half the age plus 10 for female. And C-reactive protein, again, usually if they have giant cell arteritis, that's going to be sky high. When I have a patient in the office that I'm concerned about this, I'm writing them a script, still printing it out, and I'm telling them, take this home. On the way, you're going to get your stat, SED rate, and C-reactive protein, and I'll call you in an hour or two and tell you whether to fill this or not. So they leave the office with that script, and that's because this is potentially blinding. You don't wait to say, oh, let me schedule the temporal artery biopsy. No, they can go blind overnight. So a temporal artery biopsy has been reported positive up to 2 weeks after starting steroids. Ideally, you want to have that biopsy within a week. Next topic on systemic disease. Patient comes in with a red eye and you lift the eyelid and they're really red on the top. This may be associated with thyroid disease. So what I want for these patients would be a free T4 and TSH. If this patient walks in the office, however, I'm going to want something else. So when this patient walks in the office, then I want a CT scan. And the reason I want a CT scan is the medial rectus and the inferior rectus may be substantially enlarged. So this is a cut through. This is like a rare patient that doesn't have sinus disease. Here's the optic nerve. Here's our rectus muscles. The lateral rectus is least involved, and that's why that looks so small. Okay. So here's a patient that has thyroid disease, and you can see how thick the medial rectus can become. This cut through the orbital apex shows how crowded the optic nerve can get. And so on visual field, you can see that this person has already had some concerning visual loss. This patient needs an orbital decompression. That usually gives them strabismus, but you're all experts on double vision now, so you would know that they could perhaps have strabismus surgery. And then the third surgery many of them require would be an eyelid surgery. So dry eyes injection, double vision that you know all about. And I showed you there the loss of vision. So send them for their annual exams. I really like this picture because the difference between this picture and this picture is 2 minutes. This is an ice test, an ice challenge. So you see the ptosis where the eyelid is right through the pupil, and after 2 minutes of ice, it has resolved. That's pretty much your positive myasthenia gravis. This is an autoimmune disease. It may be associated with other autoimmune diseases. So REST or the ice test, or in children, the nap test, because unfortunately children get this as well. So when they wake up from their nap, if they have less symptoms, that may very well be myasthenia gravis. Pupil is not involved. When you have a patient that you diagnose with this, get a CT of the thymus and test for the acetylcholine receptor antibodies. Multiple sclerosis. So the eye symptom would be optic neuritis. With optic neuritis, there may be loss of vision in one eye only. Remember, it's that optic nerve. And that tends to be over a few hours to a few days. Classic is that they have an afferent pupillary defect and they have a pain with eye movement. If you have the ability to check color vision, they often have decreased color vision. They may have all of these symptoms and have a normal eye exam because the inflammation is in the back. And you know the visual field defect is one eye. You want to get an MRI perhaps. So this is a patient, they walk in, they have a perfectly normal eye exam, but they have a complaint, so we're going to get the visual field and see that we should then study them. So here is the not involved optic nerve, and here is the optic neuritis. And then unfortunately, they do have MS because they do have these lesions that are involved. We started with brain tumors, so I want to end with pseudotumor. Pseudotumor looks like a brain tumor, acts like a brain tumor, but by definition, they have a normal MRI. They will have papilledema, and again, we can go over what that might look like. With an LP, they have an increased opening pressure, and otherwise, the cytology is normal. This tends to be a body habitus, overweight women. It can be associated with birth control pills or other medications, can be AM headaches. So here's a picture of that intracranial hypertension. And you can follow this with a visual field, and I will also show you our OCT. I thank the American Academy of Ophthalmology for making all of these things available, and that's my copyright acknowledgement. So I do have time for questions if anybody has any. Thank you. I'm to remind you to wait for the microphone before you ask your question. Yes, Dr. Moore.
For the pediatric patient with a negative rheumatoid factor, what's a positive ANA? What's a titer that's considered to be positive?
Well, the one I saw this morning was 320. I'm not sure that I have that definition, but I certainly can email you it.
Okay.
Because you're right. I think just off the cuff would be, 1 to 80. You don't worry about above that. You're considering it positive.
Question, Dr. Lehman. So I have a difficulty sometimes differentiating between viral and bacterial conjunctivitis, because I go by unilateral and bilateral presentations, but it doesn't usually happen all the time. The patient still comes with unilateral. It can still be viral sometimes, or does it? Both of them have crusting and both of them have redness and stuff. In which cases, for every pink eye or red eye, should we give antibiotic eye drops, or some cases you can tell this is absolutely viral and you can skip the antibiotic drops?
Yeah, there's never a 100% guarantee, but the viral tends to be watery. If there's any color to it, if it's yellow, if it's greenish, I'm going to give them antibiotics. If they're an inpatient, I'm going to err on the side of giving them antibiotics. It's out in the community that I'm going to be more encouraging for them to use their preservative-free tears and their cool compresses. I think you're not going to be faulted if they're an inpatient and they have a red eye and you put them on antibiotics.
Linda, as you know, we are graded by Medicare on what percentage of patients get their yearly retinal exams who are diabetic. Do you have any other suggestions as to how we can get a higher percentage of our patients to come see you on a yearly basis? Do we need epic reminders? What would you suggest?
Oh, certainly an epic reminder would be, a basic thing. We have that wonderful electronic medical record. It should come up. I think that maybe if we have information in the lobby for patients, maybe certainly on my chart, patients should be reminded. We should send them a reminder. We should initiate that. It is very important, and some patients don't understand the importance of that. So taking just a very brief moment to just ask, have you had your eye exam? If they say no, you say, well, that's really important because you can lose vision, so let's schedule it. And then you give the note to your friendly nurse or assistant, and they can maybe do it for you. But you're right, you do want to make sure that patients get this. But yeah, we're graded on it, but also, the insurance companies, they aren't just purely altruistic. They're doing this because it's proven benefit. I have a patient that I did 12 spots of laser on, 8 years ago, and they still have 20/20 vision. So it's really important that they have the exams. And, I'm always very enthusiastic. If it's normal at the end of the exam, great, you did terrific. It's also another opportunity. I don't know if you guys know this, primary care people, but when patients come in, I go through what's their hemoglobin A1C and what are they doing. And, I try very much to encourage their compliance with their diabetic regimen. Dr. Hallberg.
Hey, Linda, if no allergies, what is your antibiotic of choice for bacterial conjunctivitis?
I currently use siloxane because it's a third-generation fluoroquinolone, so it is generic. It doesn't sting very much. So that's going to be what I usually default to. Now, there are exceptions. If I'm worried about strep, I might do something. Gentamicin is pretty cheap, and it works well. I am not at all critical of anybody who still uses the old sulfa because that covers the staph and strep. I don't use it personally because there are some faults in it and it tends to sting, but it's inexpensive and it's not necessarily a bad first line. A lot of my colleagues will use Polytrim. There's some advantage to that. But I think, the fluoroquinolones, when the third generation came out, they were pretty much miracle drugs. So now that I can get that generic and it, anything hurts an eye that's sore. But I've used all of these in my eye, and I tell you, that one stings by far less than certainly than sulfa and a number of others.
Linda, it's not like your staff doesn't have enough to do already, but
right.
Would you guys consider, like mammogram people, they send a card every year for, so that'd be a possibility if they come in for eye exam, diabetic routine eye exam, send a card.
Well, I encourage them to make their appointment as they leave.
Yeah.
So I give them the slip and I say, go make your appointment for next year. And if you don't know your schedule, well, that's all right. You can schedule it. And I encourage them by saying, the receptionists are going to work with you to change that time. So make your appointment when you leave. I think the person who walks in the door is not so difficult as the person who never walks in the door. Yeah, but certainly, we have the epic, we have the ability. We should certainly get people in. I think she's bringing you the microphone there, Tracy.
I was just going to say one more thing. Dr. Kitchell, every year we're supposed to have patients with diabetes get an exam, but once they have any diabetic retinopathy, they need to be examined at least every 6 months. And once they have macular edema, we usually see them every 3 to 4 months because they can have macular edema and have very little symptoms but have a lot of fluid back there, especially if one eye's still good, and swollen nerves over time die. And, you don't want them to lose vision, so they need to be treated. Thanks.
So anybody who has time, this is an OCT, our new kid on the block. We need to autofocus it here, so. Well, so were some of my visual fields. Okay. And Tim, are you running down to save me? Okay. So if you can see that, I guess we can just kind of go through this a little bit. So this would be the right optic nerve is the gray. The amount of cupping is the light gray. This is going to be, we want to save the neuroretinal rim. Now this particular, see how this is above the normal? This actually is a patient that I was following for papilledema. She's actually much better with this test. Her original one was off the chart. You couldn't even see it. So this is a patient that actually has pseudotumor cerebri, and I use this test in addition to visual fields. And of course, clinical judgment is first, but to see that she is substantially better. that this is the nerve fiber layer. So again, here's our optic nerve. This would be the neuroretinal rim. So I'm going to show you one that looks quite different from that. Hopefully it'll still be focused. So you can see from the appearance of the optic nerve, this actually is a patient with glaucoma. We want to preserve that neuroretinal rim, and that's down. And you know, things are color-coded. Green is good, yellow is caution, red's a red flag. So sometimes when things look normal, except they're red, we call that red disease. So that would be not true disease. And then I wanted to show you the macular thickness one as well. So thank you to Dr. Kangas for finding me this. You can see here's the optic nerve, here's the macula. I showed you how sometimes it's color-coded for us. We get the RPE and the retinal pigment epithelium, the interliminate membrane and the retinal pigment epithelium combined here, and you can kind of see then which is causing the edema, and you can kind of localize it here as well. But you know, when I showed you that nice one on the slide, how it dips down, this is obviously abnormal, and this person needs to see Dr. Kangas. Any other questions, concerns, comments? Well, then I thank you very much for your attention.